good afternoon, or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and Managing Editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar, which is going to be a panel discussion called What Top ACOs Are Prioritizing for 2026. This is presented by Avery Telehealth. And the panel today is featuring Palm Beach and Pearl Health and more, and we'll get into introductions here in a few moments. A couple of notes, just some housekeeping items before we get started. Everyone is joined today in a traditional kind of webinar format. This is a listen-only format, so you don't need to worry about turning off your microphone or your camera or anything like that. We can't see you or hear you. However, we are going to have a time for some audience questions towards the end because we do want to hear from you. And if we've got a big audience today, so if you do have a question for any of our panelists, go ahead and drop it into your attendee module. There's a space there specifically for questions. We're going to get to as many as we can. If we don't get to yours, though, don't worry. Someone will make sure to reach out via email to get your question answered. Also, the session today is being recorded, so what's going to happen is after we conclude, maybe you're an hour or so afterwards, you're going to receive an email to the same email that you registered with, and there will be a link to the recording, as well as, we only have a handful of slides here, but some contact info and that kind of thing, into the slides from today, and that will come to you this afternoon. So with that being said, at this point, I'm going to turn it over to Mr. Mark Aspenson, and he is the Chief Executive Officer of Avery Telehealth, and he will introduce our panelists for today. And he will be moderating our discussion. So welcome, Mark.
Perfect. Thanks, Garrett. We're honored to sponsor today's webinar and really grateful for guys participating in our panel discussion today. On our panel, let's see here. We have Dave Klebonis from Palm Beach, Beau Munoz from Pearl Health, and Mark Reardon from Closed Loop. Mark Reardon's very lucky that we invited him to be part of the panel, even though he doesn't have a beard. So it wasn't just a beard-only panel for today. But what I wanted to do to kind of start things off, this is a very open dialogue webinar that we're putting today. Everyone knows kind of what you guys are doing now, but I thought your backgrounds were really interesting and diverse. So I'd like to kind of start things off by having you guys tell us a little bit about kind of your background, kind of what you're up to today, and then we'll kind of dive into what you guys have got accomplished in 2025 and what you're seeing in 2026. So I'll just kind of go in order of my little wheel of people here. So Mark Reardon, do you want to start?
Sure, thanks Mark, and thanks for hosting us and Avery Telehealth as well. I'm Mark Reardon, I'm the Chief Medical Officer at Closed Loop. I originally trained in medicine, but I've focused my career at the systems level where delivery, policy, and technology intersect. I've led value-based care operations across the payer, the provider, startup settings, worked on redesigning national quality strategy at the CMS Innovation Center, built close to $1 billion full risk operations from scratch in value-based care, and now I'm working on AI products at Closed Loop that can actually deliver measurable clinical and financial results. Quick background on Closed Loop, we're bringing AI into care delivery. We've got Healthy, which is our patient-facing AI applications that helps patients personalize and live care plans that are recommended by their physicians. And my focus is innovation and care models. And historically, that's been heavy on the staffing side, and we've had a bunch of innovation across nonprofit, federal, and then value-based care growth. And I'm excited to intersect that with AI and new models and providing new opportunities for ACOs to reach their goals using technology and care model innovation together.
Marvelous. David, you're up.
Awesome. So thank you so much for having me. David Klebonis. I'm the president and COO at the Palm Beach Accountable Care Organization. My background is business and technology trained. And so, expertise in workflow analysis and design, and applying technology to make systems better. My whole career, I've worked with physicians. I work great with Dr. Reardon and Dr. Munoz here, because I make a really good tandem, working with a physician. But much of my career has been, building companies to, enable physicians to be more efficient in their office and make more money. And then when the ACO idea came up 13 years ago, I was immediately attracted. I drank the Kool-Aid. I thought this was the future. And the journey with Palm Beach ACO, it's well documented. It's been an incredible ride, but it's 100% physician owned and operated. We've been fortunate to save Medicare over $800 million and distribute $423 million to physicians. If you want to engage physicians, I highly recommend distributing $423 million. But we're not just Florida anymore. So Palm Beach ACO is the largest ACO in Florida, but we now operate in 30 states. And if you like what you hear and you feel like you can help, we'd love to come to your state. Thank you.
Terrific. All right, Beau.
Yeah, great. And it's awesome to come in third and talk about kind of like the intersections between myself and Mark and David. And so, so Dr. Beau Munoz, a medical director at Pearl Health. Pearl Health is a national ACO across 48 states, representing 2.5 billion in underwritten contracts and about 350,000 lives. I, like Mark Reardon, graduated from Duke Medical School, and I did 20 years as a physician, general surgeon, surgical intensivist. Before finding my way back to the health tech industry, I'd done a fellowship in predictive analytics and found Pearl Health right as they were in their kind of inception and came on board as one of the early employees. And at the time, we were looking at, to Mark's point, ways to use technology to really optimize performance of physicians in their value-based contracts. And over the course of the last 4 years, Pearl Health has evolved into kind of a bi-directional approach of using technology to optimize, but then also building out the clinical management and care coordination strategies to further optimize performance in ACO contracts. And so really excited to be here and very excited to talk about what we've done and where we're going, because I do think right now, value-based care, I think, as everybody will agree on this call, is at an inflection point. And so defining what's going to be where strategies are going to have to direct themselves over the next couple of quarters and couple of years, I think is truly a salient point today. So thanks for the invitation.
Yeah, absolutely. So before we dive into 2026 and what your kind of priorities are, let's talk about how did 2025, kind of turn out for you guys? What worked, what didn't work, and how is that going to, take a look at what you do in 2026? So Beau, you want to kind of start with that?
Yeah, so 100%. So I think, obviously, as everybody knows, there's a couple of limbs to value-based care that you really have to perfect in order to be successful. And so those strategies, of course, start with data. So acquiring the right types of data and then, digesting that data and conceptualizing it and turn it into insights to drive to your clinical partners and clients. That's number one. So fundamentally, investing in the right types of data and then turning it into actionable insights for physicians was absolutely kind of primordial in the value-based care space. And so that's what's really been working well for us. And of course, we continue to kind of iterate on that and improve, the types and kinds of data that we get, and then how we arm that and give that to our providers. And I think secondarily, benchmark accuracy has been critical. There's been some major changes, V24 to V28. And so maintaining benchmark accuracy in that environment has been important. Once again, that goes back to data and then the tools that you use to allow providers to access and appropriately account for appropriate HCC coding. So that's been important in 2025 going into 2026. And then I think, nobody can divorce themselves from what David mentioned, and that is driving this economic value to providers. And so finding ways to get money back into their pocket and help them facilitate what they're doing is, of course, key. And so I think that we've established a couple of really great programs in terms of bringing value-based care workflows and corresponding economic value that comes with that and driving that to physicians. Coming up with some techniques to do that have been valuable for us in 2025. And then I think, the most important thing is integrating into workflows. So how do you get your insights? How do you get your value? How do you get your incentive structures to align with provider workflows and getting to their care coordination and care management strategies, finding the best ways to do that seamlessly without friction and really accommodating to whatever kind of workflows they have. So finding those direct strategies has been key for us in 2025. I think as we go into 2026, figuring out how to build on that and then just driving as best we can to optimize each of those subsegments, because it is only getting harder. The transitions that are going on in CMS now and in some other value-based care contracting entities, it's making it more important to be able to do that. And so I think that's what we're thinking about, amongst other things, for 2026.
Okay. What's your recap for 2025, David?
Yes, sir. We've always prided ourselves on finishing the year strong. Medicare patients and commercial patients, they all go to the emergency room more in November and December on a ratio than the rest of the year. So this is really where we pull up our pants and buckle down to make sure that we can perform, to make sure the year meets our expectations of our participants. The way that we look at things is we look at labor performance, and then we look at all the tech and services that we can do to help our practices. And if we're going to finish the year strong, we have to make sure that every single moment is made maximizing meaningful interventions. So we have great reporting. You can't manage what you can't measure on how much transitional care management are we doing, how many wellness visits and ER frequent flyers are we getting in before the end of the year. And we're just all systems go to make sure that our practices and our team are working as hard as they can to finish off the year. And then here's where it comes to the challenge is the practices can only do so much, and they're very busy, and the holidays are coming up. And so how can you do more with less, right? And so what we're doing to finish off the year in a little bit different than we have before is we're embracing technology. We're embracing AI. AI is a pretty scary term. People think of Skynet, it's taken over the world. So internally we use a robotic term so that people know, hey, these are trusted systems that may be calling on your behalf. But the reality is if we really want to accomplish our goals, we need to use technology and some of this robotic automation so we can do a lot more with less.
Okay, terrific. What about you, Mark?
I'll answer this for what I'm hearing from my value-based clients, and then also on the health AI standpoint.
Sure.
What we heard from 2025 is a lot of headwinds, right? So we heard skin substitutes, that made the news, right? $10 billion in 2024 of skin substitutes, question mark, fraud, waste, and abuse. So I think that certainly, has been some headwinds. Medicare Advantage has been in the news. If you're following any of the publicly traded MA payers, they're not doing quite so well, and it's because some of the underlying policy changes and dynamics there. And then underwriting overall. So you have the right infrastructure in place to underwrite the risk and recognize what risk you're bearing. The point of optimism, and I know we haven't gotten to 26 yet, is all three of those, I think, flip to positives and tailwinds in 26. So that keeps me ending the year on a pretty positive note here. On the health AI front, we have moved so fast and so far in just one short year. I think about the start of 25, where when I would get in front of physicians, there was or technology leaders even, there was a near universal consensus that you needed to build your own AI LLMs. You need to train your own healthcare specific AI approaches. And so millions or hundreds of millions of dollars was spent on these models that are just limited to healthcare. And what we've seen is a lot of the commercial LLM models have actually improved significantly in the last 12 months. And so that's opened up a lot more opportunity for ACOs, healthcare, and even non-healthcare opportunities in AI, which we're seeing in the news. And then the other piece is, which I'm really optimistic about, is the physician engagement with AI has increased. And we probably saw that at the tail of 25. A lot of that's with the power and promise of voice transcription. So we've now got tools like Abridge and others that are in physician offices, and they've taught physicians, hey, we don't need to fear AI. It's actually really effective and accurate, and when deployed appropriately, can get docs home hours earlier to their kids, eliminate the pajama time that they had, and so much personal satisfaction brought back to the practice of medicine. That, to me, is a real exciting force in AI for 26.
Great. So as you kind of look at 2026 ahead, we talked earlier, what are things that people you see are going to be doing, Mark, but then you also talked about some subtraction of stuff that people aren't going to be doing. So where do you see things going in 2026?
When I look at things, I see three major priorities. I see executional automation. So as we shift from this concept of predicting to actually executing, And so we might rethink old approaches in favor of faster to execution, faster to results, and we can use technology to do that. And we can also use technology to make humans more effective in doing that as well. And then the second is operational resilience. So do we have the right data? Are we managing risk at the level of basis points? Do we understand that? And have we learned our lessons from some of the changes in Medicare Advantage and compounded by the skin substitute challenges, and recognize that the data accuracy really matters there? And then last is trust. 2026, we've got to have trust in the tools, trust in our processes, and trust with patients. And that's where I think this comes full circle, because when we can deliver the right care experiences to patients that allow them to live happier, healthier, longer lives, they will trust us. They will trust the physicians in the ACO that they're a part of, and they'll come back to them. You see that obviously with Palm Beach ACO and many others, but those are independent docs that the patients come back to year over year over year, despite having in South Florida lots to choose from in the healthcare front. And I think comes back to trust.
Okay, great. David, what about you for 2026, and how do you, specifically, how is digital health and how is, AI going to help you achieve, what your goals are in 2026?
Sure. I want to share what I think would be most helpful to the audience. And I think the reality is, there's going to be leaders that get in trouble. They may not even make it through based on their AI decisions. And, we've already seen some folks, they overcommitted to AI. So they spent millions and millions of dollars on multi-year contracts only to see that the use case didn't pan out, or that same service is a fraction of the cost, just months later. So, you can overinvest in AI. And then certainly I think that, given that we all have to do more with less, if you don't make any technology or AI commitment, you may find yourself falling extremely far behind. So, the approach, for my leadership is, make sure you have some adjacent, some, low commitment initiatives at all times. Make sure you have more than one, because you never know exactly how each one's going to pan out. And then by doing that, we have 3 initiatives in AI, each of different levels of maturation, and we've been surprised by the results. So, we talked a little bit about the robotic calling, and that has had good results, but it's been a stalemate a little bit with EHR integration. We use an AI chatbot through our partners here with Closed Loop, and that has had great adoption, but at a relatively low scale. And then the third item is the AI scribes that Mark has described. So, many of our clinics, they needed help, getting done with their visits and getting out of the office, but we found that we could only really take care of the groups that were most engaged. So the important thing is we're learning on AI and we're embedded. And so, if we need to pivot in the future, we're going to be poised to do so.
Okay, great. What about you, Beau?
I want to jump in here, because I think, since Dr. Reardon brought up AI first, it's now incumbent upon him to be the one that's going to explain, in detail, the big question that I see popping up on the blog post, and David kind of alluded to it, is okay, so there's, we're all bombarded with AI, but what's the real applicable value of it? I mean, and everybody's familiar with AI scribes, but as David pointed out, we've been bombarded with a full spectrum of AI tools for just about everything. But what's the real value of it today? And then what can we expect for 2026, right? So I think that's something that you can't live in today's environment without thinking about it for 2026. But obviously Mark Reardon and I talk a lot, and so I understand he's got a lot of expertise in this, and he's got some great thoughts. So I think it isn't good for the audience to know what and I really appreciate David's comments on this is what we're doing, this is what's kind of working, not working, because I think that's what a lot of people are frustrated about, is that okay, I feel like I have to be doing something here, I don't want to miss the boat. It's kind of the FOMO sensation. At the same time, what of this is really valuable, what's really working, what can I actually leverage, what has a strong ROI. So yeah, I mean, we're definitely thinking about it for 2026, and I can certainly talk about how Pearl Health is engaging with AI and deploying it. Mm-hmm. I really appreciate kind of Dr. Reardon's insights on this, and he's been a thought partner. So I will thrust it back to him, since he was the first one that brought up AI in the conversation. He gets that honor.
All right, I guess I'm not going to open my mouth anymore. When I think of value today, a lot of it's back office. right? So a lot of the credibility came from the voice agents. It came from process improvements that we're seeing behind the scenes in 2025. And then we had pockets of innovation happening, like David mentioned. 2026, the value unlock is going to be new data signals. So you heard a lot about data from David and Beau. When we think about data in value-based care, any value-based care leader is going to rattle off claims, ADT, lab feeds. There's a whole host of data that patients have locked in their brains and locked in their experiences in the healthcare system. And as we think about utilizing AI to unlock that data and bring in new data signals, that flows back to underwriting, that flows back to clinical, that flows back to physicians, that flows back to ACO leaders. 26 to me, for a progressive ACO, is figuring out how do we proactively capture that data. For us, I spend a lot of time thinking about how do we build applications that patients can engage with. It can also be telephone calls. It can be a whole host of different levers. Well, I'm sure we'll see new ones in 26 as well. Let's capture that data and then translate that into action. Translate that into changes in our thinking about the risk that we're taking, changes in thinking about our gap closure programs. From a telehealth lens, Mark Aspenson, thinking about proactive outreach using a human to capture this data, but we've preceded and understand which patients are most appropriate for human engagement, those sorts of things. But it's a rich new data set, and I think 26 will be fun to watch how that unfolds.
Yeah, it shouldn't be a crapshoot of who you're doing outreach to. It should be very targeted. Yeah.
And really quick, I want to give credit to Mark Aspenson and Avery Telehealth for like defining and being at the central hub of like, where does it make sense? Where does AI leave off and humans start? So like, all credit to you, Mark Aspenson, the company that you created in Avery Telehealth, and like having great data infrastructure, but also recognizing where that component ends and where humans need to be involved, and bringing to bear, the appropriate clinical personnel to do the things that AI is just not prepared to do, and kind of filling that gap. I just want to recognize the kind of effort you put in that, and the great company you built to leverage that. And so just want to recognize that.
Thank you.
If I could stack onto my colleague, Dr. Munoz, I think a belt and suspenders approach is critical. So, if you have an AI only plan and there's a variety of contingencies that can occur, you may end up in a really bad spot. And that's why we like our partners at Avery, is if you have someone that can scale care management and scale telehealth when, maybe automation can't, or maybe your own in-office resources can't, that's an amazing lever to have when you need it. And, I really enjoyed meeting and learning about Mark in that respect. I wanted to comment on AI is you got to follow the zeros. And so, if you look at, cost savings of revenue cycle management, maybe you can completely eliminate the labor or the growth in labor of your back office. And so maybe you save $1 million a year, right? All of us are so blessed to work in value-based care where we're literally managing billions of dollars of total cost of care. And if you can leverage AI to not just save on labor in your office, but actually do a lot more care management to the patients that need it the most, the ROIs can be 10, 20, 30 million. And so I would urge you, when you're considering your AI decisions, is to follow the zeros, because you can end up really rewarding yourself a lot more if you do so.
Terrific. So part of that kind of leads in, Beau, is there something you really wanted to talk about what Pearl Health is doing for 2026 as far as a couple of your initiatives?
Yeah, no, I think that, so like right kind of near term, like the shark closest to the bone, I think David alluded to this as well, like, a lot of value and a lot of dollars tied to kind of all-cause readmission, transitional care management. I think those are really high on the list. I feel like, and I would credit Palm Beach ACO on my knowledge of what they've done and what they've created. I think they've done a great job of kind of like capturing the low-hanging fruit, as I think most ACOs that are kind of still in the business and still big players have done. And so, the benchmark accuracy, kind of patient management, patient workflows, and then getting the appropriate data markers and driving those to physicians. I think all of the best ACOs are doing that. I think we're now reaching a kind of like asymptote where doing that is going to become harder and not enough. And so looking at those kind of marginal value that driving all-cause readmission, unplanned admissions, ER visits, unnecessary specialty care, unnecessary specialty meds. I think those are all kind of high on our target list to grab that fractional marginal value, which when amassed across an entire panel can generate, significant 7-8 figure returns. So I think that's what we're thinking about. Like, we're thinking beyond, and I really think that any successful ACO or value-based care entity has to start thinking beyond the low-hanging fruit. I think the different regulatory changes being pushed by CMS has made it such that you really have to start getting into the varsity level tactics. And so that's what we're thinking about, is how do we really, really drive down those all-cause readmissions, unplanned admissions, high-cost specialty, as well as like pharmacy spend. And then, of course, as Mark Reardon brought up, the fraud, waste, and abuse. You have to build up systems that are going to catch that early and act on it often. So that's, of course, at the forefront of our minds. But that's so variable that I think hard to have a strong strategy around that. But really, I would say all-cause readmission, transitional care management, and then to a certain degree chronic care management as well.
Yeah. Well, and as we talked previously about, part of the challenge with preventing all-cause readmissions is knowing someone's admitted, right? So making sure that the markets that you're in, I know one of the markets you're in is, the HIEs you're only getting about 40% of the feeds. So, finding out how do you work around that to make sure that you really have your finger on the pulse for when people are admitted, not just getting some blind ADT feed of, they were in this, hospital for at this date, but you have no idea why they were there. You don't, you get notification that they were discharged 10 days ago. And then your quality metrics is that you have to have an RN follow up with them in 48 hours and then an APPN follow up within 7 days. So it's how do you get that quality measure accomplished, within, 48 hours and 7 days if you were just notified that they were discharged 10 days ago?
Yeah, exactly. And I really quick, I want to take advantage of the panel we have here, because what the audience is getting is experts in the value-based care field. And, some of the comments that I've heard so far demonstrate that expertise. And so at a certain level, like, David, Mark Reardon, Mark Aspenson, all experts at the low-hanging fruit, right? The basic blocking and tackling is kind of, our bread and butter, and we can do that, and we can do that well. And then you start to try to get to that varsity level, and you start to realize that there are systems level things that are kind of out of your control, but you have to find a way to solve for those difficult problems. And I've seen some of the work that Mark Reardon is doing, and obviously aware of what Palm Beach ACO and David's team are, some of the work that they're doing. But at some point, we even meet our limitations. And to your point about HIEs and data interoperability, like, all of this is built on that foundation of having good data and measuring the right things. And so I'll be interested to see in 2026 what happens from a systems level in order to kind of help build out the infrastructure that is necessary for ACOs to succeed. I'd be interested to hear from David and Mark kind of like what they're seeing, what they're thinking about in terms of like systems level problems that need to be solved that are maybe outside of the direct reach of a ACO enabler.
Mark, can I jump in? I just went to a conference, and the presenter was an attorney, and boy, he scared me on the dangers of ChatGPT. And it feels like when a patient goes on and asks their wildest life story or clinical ailment, something very personal, it might not be the safest place to do so. What are you seeing as far as chat in healthcare?
When I think about chat in healthcare, there's a big distinction from consumer and healthcare grade. And so when you think of healthcare grade, you've got common patterns that are maturing, and those are LLMs with zero data retention policies. So that means that none of the data is retained by the large language model vendor. We see things, obviously basics like HIPAA, SOC 2, all those information exchange requirements. But I think we've largely passed a lot of those issues when the right contractual arrangements are in place. And so I don't see that quite as big of an issue in the right context if you've got the right organizational framework in place. what I would say is got to make sure you're working with healthcare vendors in this. The consumer grade applications will not live up to expectations and might open you up to significant risk. If you go on ChatGPT, you don't have an expectation of privacy. The bottom of every chat on that window, it says ChatGPT may use this to train our future models. I've heard recently Meta is now doing that with messages within their applications as well. So they're all using the training data that you provide to improve their models, which means they're consuming your data as well. In a compliant healthcare infrastructure, that should not be the case. You should have zero data retention policies. You should have HIPAA, SOC 2 compliant pathways. And in the future, does this mean that there are tighter approaches there? I don't think it's needed now, but you can see a world where even these models are run locally or on-prem or AWS hosted. So you've actually got your arms completely around that. You really don't have as much of that data is leaving my infrastructure and coming back situation anymore, even in the future.
Yeah, but to expand on that, Mark, I think David's also asking, like, the actual patient themselves, are they now replacing WebMD with ChatGPT and diagnosing themselves with ChatGPT? I mean, because that's extremely dangerous as well.
That was my first worry about a year and a half ago, that, hey, we're going to have a lot of patients with new diseases, new diagnoses that they're coming in. And we heard a lot of it from docs saying, hey, I don't want my patient showing up with a whole roster of, I think I've got this, this, and this, and this. My experience has been the opposite, that when you actually have a trusted, non-judgmental source, I'll give you a perfect example. Just last week, I review a lot of our conversations from a quality and safety lens to make sure part of our safety and accuracy program, a patient had mentioned, I don't want to take my statins cause dementia. Now, if you're in a physician office, you're going to have a varying output from that conversation. The physician might dismiss that comment, or unless there's a really strong trusted relationship, you can see how that could break down that trust between patient doc. ChatGPT, not so much of a concern. It just goes and says, okay, I hear your concern. Here's the data. It really doesn't play out. That's not what we're hearing. You want to talk about this further, and you can have a 30-minute conversation about, and at the end of it, most patients educate themselves, learn, and then they move on to the next thing. And so I really just haven't seen that. And I've seen it actually be more helpful in educating patients about the realities of what might be causing disease and pathologies.
And I'll jump in here to get real provocative to dovetail off of what David was alluding to in the ChatGPT and the fear. So really provocative here. So there was, I heard a conversation recently, and by the way, I think ChatGPT and Gemini have gotten real restrictive. They're starting to become a little bit more frightened as well. They'll share less and less information. They seem to be, the guardrails are kind of cinching down lately. But I will say, I was listening to a conversation recently that suggested that since ChatGPT and Gemini and these other LLMs can pass the medical boards with 100%, should they not be granted board certification and be thought of as actual physicians, and the interactions between the AI and the patient be secured and considered doctor-patient relation? And we go into all the kind of nuances and particularities of board certifying or bar licensing LLMs and AI, but it is something to consider. It's definitely something that's risen into the kind of general dialogue in society, and so as these things become better and become more prominent, I think that is something to keep in mind.
Very good. So as you guys get back to the ACO side of the equation of measuring success, I know, Beau, we've talked previously about it's not just the number of covered lives per se, but how do each of you kind of look at how do you measure success other than just straight shared savings and covered lives?
I think really, if I'll start off on that, but I think in terms of I think we're starting to move. Pearl Health is moving a little bit further upstream into kind of like health system enterprise level clients. Mm-hmm. And once again, it alludes back to what I was talking about. You start to get into systems level problems that you have to solve. And so for us, like, defining success is becoming less and less about just serving and kind of servicing individual practitioners and keeping our individual providers happy, and now influencing large system level value-based care plays. And that goes into threading a needle between meeting the needs of potentially one or more hospitals and what kind of the incentives that drive them while also matching the value-based care incentives and needs of the individual provider. And that is a delicate exercise. And I can go into the particulars about that, but really kind of refining that sport, which is different than overall value-based care for maybe an individual provider or an IPA or MSO or something like that. When you start getting into the health system level and dealing with enterprise clients, it becomes a very, very tailored and nuanced approach. And so I think we're starting to discover and figure out how to define those value metrics when you're dealing with a system-wide level.
Troy, what about you, David?
I really respect what Beau said is, at some point in time, the blocking and tackling is not going to yield the same results as it always has. It's designed to be, slightly harder, very fair, but slightly harder benchmarks in our respective programs. And, the concept we think about is tell your friends. So, we build a hub and spoke model. And the reality is if we have a single practitioner in Iowa, they're not going to be nearly as effective as if we can get a critical mass of 40% market share. The hospitalists are involved, the emergency room physicians are involved, the cardiologists are involved, all drumming to the same tune that if I do a better job for my patient, then I can remain independent and be rewarded financially. And what's amazing is when our doctors tell their friends about their success and we're able to grow in a specific market, that's really when it unlocks so many different shared savings levers. Like I said, you can include the specialists, you can have control over emergency room and post-discharge visits. And that's really where you can kind of get to the more advanced shared savings levels and more advanced concepts that Dr. Munoz discussed.
Mark, what do you have to add to that?
For me, it's engagement. And if I'm putting my shoes in ACO leaders listening to this, you're going to launch new programs in 2026. Got to think about patient engagement. Obviously, that's unequivocal. And then it's the physician engagement. And one of the lessons we learned, it was a hard lesson to learn, actually, was one of our early deployments. We rolled out a tool, really excited to see it. We know it have strong impact on the patient population, but getting the physician adoption was a little bit more challenging than we were expecting. And you've got a busy physician practice. They're stretched thin. Even if you're offering something that really will move the needle, whether it's in-house or through a partner, you really have to figure out a way to make sure that docs are bought in. And in a resource-constrained environment, time, everything else. For us, the solution was, hey, let's capitalize on a new Medicare Advanced Primary Care Management revenue chassis so that now we're bringing something to the physicians. Hey, now we've got a new revenue to support the investments you're making in advanced primary care. And that helps offset the additional asks. But it really comes down to engagement. Make sure you've thought about engagement from all directions and all sides, whether it's a new program, a new partnership, a new rollout. That's critical, doc and patient.
Great. Well, kind of expanding on that, we do a lot of engagement. I think the big thing is measuring the programs that you're putting out there. What we look at is really what's your active decline rate. So, how many people did you offer a program to and they said, I'm not interested, versus taking this large population, you got 15, 20% bad data. They're not even eligible to engage because you can't get a hold of them, right? And then you go kind of down the line. So certainly, your overall total engagement is important, but also, your active decline rate is really should be significantly under 10% is really kind of, the target, as it relates to an engagement number. What else anything else you guys want to close out before we, talk about, get to the kind of Q&A section?
Mark, what's your perspective on telehealth? So, we've depended on telehealth so much during the pandemic. The law doesn't allow it at the moment. What are we going to move back to visits? Are we going to capitalize on waivers? What do you think the future looks like in telehealth?
Well, I think it's pretty bright because it's far more efficient, right, for everybody involved. So, anytime that you can do telehealth and digital health, where just like today, we could sit and do a visit, here in our office. We don't have to go, travel to get to one location or the other. Your NPs are able to see a heck of a lot more people in a given day than going to do home visits, from that, reimbursement model. And then I think in addition to that, it's, working even within the health plan side of the equation, where it's a lot of more instant savings if you're able to reduce unplanned hospitalizations, checking more of the boxes of the quality metrics that you guys are for HEDIS measures and those types of things, where you're able to build a relationship with them over the course of time, just like kind of the doctor's office. But if you're connecting with them, a couple of times a month or once a quarter, where you're actually building a relationship, you're going to get far more value out of that. And then what you're talking about is from a total cost of care standpoint, the ROIs are pretty big. So I certainly think that on the per click type of scenario where the reimbursement isn't as good as the in-person visits were prior to COVID, I think for total value, when you look at holistically over a 12-month period of time, certainly having telehealth be a big part of that option for people. And then I think also, David, the adoption rate of telehealth as the population gets a little bit younger and more accustomed to doing video visits, and they're not afraid of video visits, and they have met the person on the other end of the video visit and have a relationship with them, you're going to have a lot better success and adoption with that. I mean, if I go to the back of my Blue Cross Blue Shield card and say I need a telemedicine visit from one of their connected providers and I've never seen that person before, I think you'd be better off having a visit with your primary care physician that you see once a year, but you have a follow-up visit once a quarter, and it's the same doc, right? It's just done more efficiently through video and through telehealth.
Awesome.
Anything else you guys, Mark or Beau, you want to add?
I think that's good. I'm ready to get to the questions. Really quick before we sign out, I do just want to give credit to Mark Reardon and David Klebonis. I mean, I'm obviously very aware of what Palm Beach ACO has accomplished, and I think that David set it out really well. I think kind of like in leveraging that closely tight-knit value-based care playbook where you kind of regionalize, create specialty networks. I really just want to kind of give them credit for developing a really great ACO in that sense. And obviously being out here in California, they're even out here in California, so not just Florida. And obviously I admire the work that Mark Reardon has done and the Healthy app in terms of patient engagement. It's pretty impressive. So I would encourage folks to go check it out. I think you can get it in the App Store, right, Mark?
Yep.
In the App Store, that's for sure.
All right, Garrett, what do you got?
Yeah, very good. Well, we do have some audience questions. And by the way, if you're out there and you do have a question for any of our panelists today, go ahead and drop it in now. You have a little module that's just for attendees for questions. So go ahead and put it there. We're going to get to as many as we can. But if we don't get to yours, don't worry. Again, someone will reach out to make sure your question is answered. So in no particular order here, let's go ahead and dive in. The first question is this. I was wondering how you are dealing with disparate data from various payers to monitor and manage your programs and assisting providers with training and education to improve their outcomes, not just in quality, but also in risk and cost. So I don't know who that's directed to, but maybe if you guys have any thoughts on that.
I can comment on the quality side is, I think our payer partners have the best intentions, but it's surprising that some have 4 quality measures and some have 13 and some have 20. And so as a service to our providers, we create a universal template. Now, our medical leadership will say a lot of it's standard of care, but in order to make sure that you're putting your work in the structured data location, make sure that it's automatically submitting the CPT2 codes, that takes a little bit of work. And so what we do is we create a checklist at the beginning of the year, because these measures change, and we do a lap around the whole membership, and we make sure all of them are using the comprehensive template so they're getting the most credit for their work.
Very good. Let's see. Next question here is, what are the thoughts on remote patient monitoring given the recent announcement from UHC that they will no longer cover RPM with the exception of specific diagnoses in 2026?
I can take a stab at this one. We've got to have programs that have strong ROI. they've got a and when I say ROI, I don't always mean dollar. I mean human impact and patient impact. And sending grandma a blood pressure cuff and asking her to take her blood pressure 17 times over the month isn't always aligned with an overall goal of improving health. It's part of a coordinated approach to improving her health, and it's prioritized, and we've got a patient that we need to actively manage and titrate medications, absolutely. But the concept of we're going to roll a ton of folks into RPM to build those codes really didn't make sense from the start. The spirit is, how do we afford to pay the healthcare system to have a more proactive approach to monitoring patients? So that spirit, in my mind, still stands, but it was the implementation, the capitalization on that. And so as an industry, we've got to think and set a high bar on these types of approaches too. Will it improve health? Will it improve costs? And if it doesn't pass the smell test, we've got to continue to look for the next option.
Well, I think, we do, RPM is part of what we do, but, to your point, Mark, it has to be for the right people, right? It can't be just a driver for, CPT codes. That really shouldn't be what it's for. It should be for those people that, have a tough time managing their hypertension or their CHF or their COPD. And it doesn't have to be forever, right? It certainly could be something where, they have to have the tools to be successful in managing their care. I mean, a lot of our transitions of care programs, when we ask if they're discharged for heart failure, we ask them if they have a working scale in their home, and 50% of the time they don't have a working scale. So it's not that they can't be compliant, it's that they don't have the tools to be compliant either. So how do you blend those things and making sure that it's appropriate for that patient for that period of time is kind of our philosophy on that.
I think that makes great sense. I'll call it David. I know he and his team have pushed us on what's your disenrollment criteria. Before you start a program, predefine the disenrollment criteria. And if you have a vendor coming to you that doesn't have a disenrollment criteria and they haven't talked about that, you should probably go the other direction or work to solve that. David's been great on pushing us on that. Thanks, David.
I really appreciate the depth of Dr. Reardon and you, Mark. Unfortunately, we've had physicians have all of their shared savings erased through RPM and some type of misunderstanding. And to be disciplined, to do it on the right patients, to speak about, hey, if they don't meet criteria, they're going to be disenrolled so that I only have the right patients. And then, Mark, to your point, if you're reducing an emergency room per 1,000, it could be one of your best ROI projects, but you just need to have the right partners and you need to be disciplined.
Let me agree with all of that, and then also just be even more provocative. Agree with everything about the discipline and the guardrails and deploying it correctly. I have also heard mutterings around that, like, what UHC is doing is pretty heavy-handed and potentially illegal to execute that on Medicare Advantage patients. I have no stake in any RPM company, and Pearl Health doesn't use. We don't have any vendors that use RPM. I will just say, like, that's pretty aggressive. Reading through that announcement, I think it's overly aggressive. I think it's overly broad, and I think it's going to have to be refined in scope.
Wonderful. All right, next question here as we move forward is how do you envision home health playing a role in healthcare in 2026?
I think I'll jump at this one and just say that, like, in terms of patient engagement and managing your patients, you kind of have to go down like one of two avenues. You're either going to go the RPM CCM where you're putting devices into their homes to monitor them, or you're bringing people into their homes to monitor them in terms of home health. Those are like the best kind of closest concierge level avenues of care to have the greatest engagement and management of your patients. You can do it with devices, or you can do it with humans. And I think that to the point about RPM, I think as RPM becomes more refined and restrictive in its scope, I think we're going to have to start leaning more on home health opportunities, whether those be executed through telehealth or through actual human beings. But I right now am on the lookout for products like what Dr. Reardon has designed, ways to have a interface with the patient at all hours of the day, all times, and what is going to drive engagement. So and I've seen other things coming out, apps, tablets, screens in people's homes, digital avatar nurses, et cetera. But I think it's going to become increasingly important as we start to, as I keep alluding to, as we stop focusing so much on the low-hanging fruit and start to get to the real like varsity level strategies. I think home health is going to be increasingly important.
So we're a value-based entity, and we don't have two canoes. We just have value-based only, and we believe that home health is one of the most valuable Medicare benefits. There's hospital, there's skilled nursing facility, there's inpatient rehab that are all significantly higher expense per day. And if you can manage patients at a lower cost site of service, then you can do extremely well in these programs. Honestly, maybe our secret sauce is we have a team of home health specialists. And if the physician would just message us electronically the plan of care, then our specialist will help them use home health just right. And if I'm being honest, we probably spend 20% of our total resources working on quality home health.
Great. Next question is, are there any billing AI options available and any suggestions, if so?
Turf that one to Dr. Reardon, the AI specialist.
I don't spend a ton of time in billing improvements because as David nicely put, in the one canoe of value-based care, optimizing isn't top of our radar. What I would say is the tangential opportunity here, as I think about it, accurate risk capture is an important component you should think about of any AI approaches. Anytime you're consuming new data from patients, it's an opportunity to use that data to better manage the patient and also make sure that you're reimbursed for the care and the complexity of that patient population. So I always use the example of got a patient with congestive heart failure that mentions they have palpitations. That can be picked up from a variety of data sources, including even Apple Health Kit. Palpitations is a standardized data element on an Apple device. That might be representative of AFib, which is commonly comorbid in patients with heart failure. AFib is an HCC and should be appropriately documented, not just for the revenue and the risk capture, but so that we manage the patient's AFib and prevent that stroke down the line and all the complexities and missed opportunities for care coordination and better management of that patient. So overall, yes, AI tools, I'm sure you can optimize your billing. There's probably plenty of vendors out there. The nugget that I would plant is think about new data sources to drive more accurate risk capture for clinical operations and for financial performance.
Great. Okay, moving right along. We got time for maybe a couple more questions here. So go ahead and drop yours in if you've got one. This one says, Dr. Munoz mentioned looking more to health systems and value-based enterprises. One of the biggest challenges facing health systems is this work of feeling like they are asking providers to treat patients differently based on how they are reimbursed for that patient. So I was at a conference recently where a large health system CFO said if we could flip the switch tomorrow and have all the payers do value-based care, we would all be in. How do you anticipate helping systems navigate this barrier?
I will say that I don't think that anybody has the solution, and this is what I was alluding to, is that as you get into these higher levels of the value-based care operations and systems, you are starting to approach areas that the answers are not defined yet. You approach more with hypotheses rather than solutions or answers. And so I would say that if there is one area where I think Pro Health is really kind of being innovative, it's in bringing value-based care to health systems, because it just so happens that our portfolio of clients tend to be larger health systems and large MSOs and IPAs. And so we've been thrust into the position of having to kind of define, for lack of a better word, the curriculum of how to succeed in value-based care in those systems. And I will tell you, it is, as with everything that we've talked about here, it is threading a needle. It is taking multiple different incentives and then trying to unify those incentives to drive value, drive the economics of all the parties that are involved. I will say that it is not easy. I think the question kind of alluded to the solution. If instantly everybody was forced to function in under value-based care economics, it'd be a lot easier. But in a system where you have different payers under different sets of rules with different incentives, it becomes like trying to mesh different sporting events into one unified sports, kind of like I think that movie Basketball or something, right? It's like you're going to have to redefine the game in total, and so that's kind of where we spend a lot of our time at Pearl Health is how we're going to redefine that game and how we're going to make the incentives enticing for all. And so I would just say, as where that is probably not an answer to the question, I will say that it's being defined right now, and a lot of it just involves bringing all the stakeholders together and then trying to unify them in their overall incentives and desires for the program.
Garrett, I give Dr. Munoz a ton of credit for their efforts and success with the health systems. You know, that is a very large part of our market, and at the surface can be difficult. But boy, I give the systems so much credit. Did you know that 5 out of the top 6 most successful ACOs in the country are system driven? So to say that the systems aren't contributing to value-based care, you know, couldn't be furthest from the truth. You know, one thing that I see with system implementation is when they're able to use it to maximize physician alignment is where they're able to really excel, because you can have common interests in we want to use the best possible providers. And if our system is at the front of the list, please use us. If our system is not in the front of the list, can you please tell us on how we can improve our service lines, how we can improve our facility management so that we can earn your referrals. And when you speak with data, instead of, you know, bringing your great looking marketing reps, you know, a lot of times you're able to connect more at the physician level, and you can often influence behavior a lot more efficiently. But we see that value-based is a great way to align physicians and then tap into these amazing value-based dollars.
Wonderful. Well, we have time for one last question, and then we'll go ahead and wrap it up here. Last question is this: do you find difficulty in competitiveness between hospital-owned groups and independent providers when working with both?
I'll start with this one, and just like, you know, to David's point, it's it depends on the system for sure, and David's absolutely right. Some of the best performing ACOs and value-based care entities in the country happen to be health systems, and those are ones that were early on in the evolution and took it under their guys to go ahead and execute and really move and shift towards value-based care. I'm thinking of, you know, Geisinger, Ochsner, LifePoint. I mean, these guys are doing great. Baylor, Scott and White. I mean, some of the most performant. Southwestern Health Resources, just to name a few. And so I think, but also to David's point, the one thing that people, I think, in general can all agree upon is facts, data, and truth. And when you can drive that and lead conversations with that, you can cut through kind of the I guess the friction or the tension between where it's a system that maybe didn't shift over fully to value-based care and is not an expert at it yet, but they're trying, and they've been largely historically a fee-for-service operation. Bringing the stakeholders together and then driving the conversation with data, as David pointed out, I think that's a key technique, but also recognizing that it's going to be an evolution. And I don't think right now there's that, you know, that unified sword that'll cut through the Gordian knot. Just being prepared to take on that exercise in a multi-year approach. And I'm not sure, you know, what Palm Beach ACO is doing, but I know, like, when Pearl Health engages with a large health system client, we tend to look for longer term engagements and contract levels. So 3 years, 5 years, because we know it's going to be an evolution. We know this is not going to be a 1 year in and out operation. And so knowing that it's going to take a while and knowing that there's going to be a lot of parties involved and trying to thread that needle, I think is key.
You know, Garrett, I really like Dr. Munoz's comment about long term, and I think that all stakeholders should look at what is the most resilient, sustainable approach. And if the systems are great at managing providers, then I think that's a winning approach, and we should do a lot more of that. If that's not their strength in the community, and they can support strong independents that are like-minded, support quality, and can align with the system, that's also a great approach. And what I'm seeing more of is the joint venture approach, because physicians, they're the top of the food chain, and sometimes they're a lot better partners than employees, and you can get a lot more value out of them.
I love Beau's comment about data, and when I think about the respect that I have for Pearl and what you all have built with a data chassis and data infrastructure, it reminds me, recently I sat down with I live up in Maine, and one of the local hospital leaders up here had mentioned we've got such a shortage of access and such a problem with access here. We use data to really make sure that patients are being cared for at the right level in the right organization. And when I think at the national level, you can broadly say access is continually a challenge. It's more of an allocation issue, which starts with having the right data of where should patients be at any given time, given their current medical complexity and needs.
Awesome. Well, I hate to be the party pooper, but we are out of time. We're at the top of the hour. I wanted to thank you all so much for a fantastic presentation. This was we got several comments in that said this is just a fantastic panel and a lot of great discussion today, and I couldn't agree more. As we close out, I wanted to encourage you all out there, if you're curious to learn more about Avery Telehealth, or about AI and some of the different things we're talking about, check out vbcexhibithall.com and their virtual exhibit booth there. There will be a link to this when we send out the slides later on, but you can read up on them and what they're doing, and of course reach out to them through the space. And this webinar will be archived there in our library at vbcexhibithall.com. So go check that out. And then finally, if you would like to reach out directly to the Avery team, there we go. You can reach out there, and I think that's Chris's information, Chris Fickle, and he'll point you in the right direction. But again, I want to thank you all so much for spending your afternoon with us. Thank you, Mark. Thank you, David. Thank you, Beau. This was a fantastic presentation. Really enjoy it. Hope you guys join us for the next one. Thank you all so much. Bye.
Thanks, everybody.
Cheers.